one of the things that the realm of PT is really diving into nowadays is imaging and ultrasound. And, you kind of specialize in this area nowadays. And I kind of want to talk about where you started using ultrasound.
Okay, so ultrasound was something that I got introduced more so as far as doing it was back in New York, which was somewhat around 2015 is when I actually started doing it. I was introduced more or less to it about another 2 years before that. And this was more so through internet, looking at other people, how they're working and utilizing ultrasound in their domain. So pretty interesting to me as I had initially previously delved into other types of imaging and reading more of those like the radiographs and MRIs and CTs, but then ultrasound was more or less something that was not touched as much. So that said, it was something that I got intrigued into at that time, and then I started basically doing self-research, started finding material that I could delve into, I could read through and gain knowledge from. Started finding anything that I was available in the market, like courses or something that I could get into. There were some courses that I could kind of see in the market, but then I was like, well, let's just first kind of have a basic understanding of it. So as working as a PT, I was like, well, let's just read through things and get a basic idea before I go into a classroom and say, hey, I want to learn ultrasound. And I don't know anything about it.
Right.
So that was more so of it. I spent about like 2 years like that, and then reading through it, purchasing books, listening to YouTube videos of professors teaching it. And then after that, I kind of went into course classrooms, and then this was through AIUM and Gulf Course Ultrasound Institute. So then I learned from them how to do it, and simultaneously found a couple mentors and physicians that I could work with and could get access to machines, because that's another big thing. Like you don't have ultrasound machines lying around in any and every clinic.
Right.
So I was fortunate enough to find a physician who was willing to work with me on that, and then basically from there, yeah, we just started doing all those ultrasounds.
Well, clearly all the studying paid off, and I want to, at least you hope so, right?
True. I hope so. Absolutely, that's true.
Well, let's put those skills to the test at least, and let's define what musculoskeletal ultrasound actually is. What would you say in your own words what it is?
I would split the term basically and say, okay, MSK or musculoskeletal ultrasound, let's take it piece by piece. MSK or musculoskeletal, we'll be looking at or trying to look at things that are, inside our body, and they are in domain with muscles, tendons, ligaments, right? Some amount of bone structures we're also trying to, see, but not so much. Ultrasounds, we're looking at diagnostic ultrasounds here. As we know that there are two types, especially in PT domain, we look at those therapeutic ultrasounds that we have been using since decades. This is a bit different. The beams, which are high frequency, energy beams or sound beams, they pass through the system of your body and basically bounce off structures in your body, come back, and the probe or the transducer picks them up and creates an image through a computer system.
Hmm.
And that is what we're trying to look at, from a diagnostic ultrasound. And that's primarily what it is. People mostly know it as, being used extensively in gynecological setups, to watch the baby. And that's one joke that we kind of look at in the clinic. It's like anytime we pull out the probe, and they're like, hope you don't find a baby in my knee. So
Yeah, me too.
so that's mostly, what diagnostic ultrasound would be here.
So when you're looking at an ultrasound, what can you see, so to speak? Because X-rays, you can see bones, MRIs, soft tissue. What are you looking at through the ultrasound?
Right. So X-rays, MRIs, CTs more commonly are being used. With sonograms, we're trying to, again, find soft tissue abnormalities, primarily, again, as I say. There are some cases where bones are seen and are also commented on. Not all of them, but again, I would say as an exception, normally we would see, and this is something that I really like to examine as well, bones in terms of rib fractures. That's where you can really, find those and can put them in perspective and say, yeah, you got a rib fracture. I know that, even if it doesn't show up on an X-ray. So ultrasounds are more sensitive to it. But apart from that, you're mostly looking, I would say 99% of the times you try to look at tendons, ligaments, muscles, cartilaginous structures and labrums. Those are the structures that we want to look at. in the entirety when you're going through an ultrasound report.
And when do we want to use an ultrasound? Like, should we be using it with every patient to confirm our findings on objective exams? Because for people who are maybe not in the realm of diagnostics, it's, when we have someone we evaluate, we use different tests, or at least have a hypothesis of what's going on, and then we try to confirm by ruling in and ruling out pathologies with objective tests. And so, but sometimes we're not always right. And so, I guess, do you use the ultrasound as like a end all be all of like this is what you have, or I guess are you using it with every patient? You speak with that.
And so the answer to that would be no, I don't use it with every patient. One, it is a time consuming user dependent modality, right? So it's not like clicking an x-ray. You go in a room and you're like, click button, x-ray's done, look it on the screen, you're good. No, you spend some time with the patient trying to find those structures and look at their anatomy, their grayscale anatomy, then you try and look at their vascular anatomy. So it's a time consuming process. So definitely it's not going to go on with every single patient I'll get in the clinic. Just like, picking up any other type of diagnostic modality, or even I would say picking up any other type of clinical test. I mean, you and me, we deal with patients on a daily basis and say, yeah, here comes a knee case, right? The patient may have, I'm thinking about meniscal tears, that might have an ACL tear. But then, I mean, I'm not going to first pick up on my differential diagnosis list and say, yeah, they might have a radiculopathy from the back that's going to hurt their knee, which is a possibility, right? So the tests that I'm going to pick is not going to be a slump test. I'm going to first go ahead and start with my, my A-police for the meniscus. I'm looking at the compression, my distraction, my McMurray's, my, all those types of things. Just like that, I would first want to do a comprehensive physical exam with the patient. And if that exam is giving me adequate findings, I'm not going to delve into an imaging just to prove a point there. But it's important to have that as a tool. There are cases where you would say, man, I don't know what's going on. This is a bizarre combination of signs and symptoms. Nothing's picking up on, in a proper set of examination tools. So where do I go with this? Let me see if I can see something inside. Now I have the ability to look inside that structure and say, no, the structure looks pretty normal. Let's shift the focus to something different.
Mm.
So that's the thought process behind that. And there are other reasons why I would use an ultrasound with a patient if I'm monitoring their progress as well. So that's I think more or less to say so. I would go for it.
Is that a common thing to use it as a way to track progress over time? Maybe it's like watching a stress fracture heal or meniscus healing itself. Is that something that you use ultrasound for commonly?
So in those two cases, maybe not so much.
Okay.
But if I'm looking at a gastrocnemius tear, I'm definitely going to look at its progression over time as to if the structure is healing or not. Do I see the fluid retention between the muscle fibers in there or not? Is the power Doppler signal decreasing or not? How is the area of that power Doppler signal? Is that changing in its intensity? And is the grayscale or the B mode ultrasound, which is basically just those 256 shades of gray that you see on the screen, are they becoming more and more analogous with your natural anatomy or not? So goes for an example of a plantar fasciitis. I mean, if I see someone's plantar fascia that is 0.2 centimeters compared to a 0.5 on their left and rights, I'm definitely comparing that 0.5 to start becoming closer and closer down below that 0.4, which is more clinically relevant to me, and their symptoms are, improving side by side. It's a real good visual aid to the patient as well in many of these cases, where they're like, yeah, I can see this improvement. I can feel it. There's a good correlation. And that's a big buy-in. I mean, by all means, every day in and out. And as a clinician, that gives me the confidence of saying, yeah, what we are doing in the clinic is actually making a difference. It's not something like you're just thinking about it and getting better.
Right. Yeah. It's just, it's definitely getting better. I promise you, it's made a huge difference, but you can actually see it. So it's nice.
Very true. Yeah.
And do all physical therapists have this tool at their disposal?
Now, with my own experience, no, I did not have it every time, right? So I think no, but it depends on the place where they're working, right? So if they're working in a setup which is like a primary care setup, I had the privilege to work in one of the setups where we had a combination of clinicians working together. We had a primary care as an internist, we had nurse practitioners, we had a neurologist, We had a PT, a chiropractor, a massage therapist. I mean, you name it. The whole thing was packed. So we had access to X-rays, ultrasounds, EMGs, NCVs, bone densitometry testing, all in that same place, and blood work as well. So yeah, if you had a question, there you go. You can consult anyone else in the field and you can send a referral in there. So it was pretty much within house. But then that's one place I worked that was like that. I've worked in 14 different places in New York City and none of them had it. So then ultimately, when I thought of using this tool as extensively as I'm using it now, I just thought to purchase it. I was like, well, it doesn't make sense to, kind of not do it if the facility doesn't have it, because I use it as a tool like a stethoscope. So I need it. Therefore, I would rather have it with me and just and continue that, information building process that is important to my clinical care.
Absolutely. And are you using other imaging tools to help roll in more information, like X-rays and MRIs? Because you said you used to do that at that clinic, but then not anymore. Is it? Have you developed a relationship with the radiology people in your area to try and be like, hey, I have this person, and I think they have I have suspect X, Y, and Z. Can we get them in tomorrow?
Absolutely. That is a real common conversations we would have with the physicians around us. We have a good network of physicians that would, refer patients to us for some reason, and so vice versa. And it's a real important piece in patient care that you have a real good network of people around you that you trust and they trust you. And these questions do come into play. Yes, I use X-rays. Yes, I use MRIs. I have a habit of asking all new patients to bring in imaging as they have got done in the past. So they would bring me the CDs if they have those. And in addition to that, yes, if a physician has those, images with them, we would request them as well. X-rays is something I would definitely use in cases of fractures, especially like we had a fracture recently in our clinic where it was a comminuted fracture in the ankle. There was a tibial plateau fracture in the same patient, and he also had fracture of the calcaneum in there. So we're basically having all three joints going in, subtalar, calcaneum, and the tibia. And then there is, an ORIF done on the patient. So that said, I mean, yes, the patient has had surgery. We know that the patient's been sent to us from a surgeon. But then when the patient comes to us from surgeon's office, they'll have tons and thousands of questions saying, when will I stop using my boot? When will I stop using my crutches? Right. And I have, with the experience that I would talk with, I can say, okay, yeah, approximately by this time. But then that experience comes in from enormous, patient clientele you've seen over the years. And in that case, also, every patient is different. How can you say that, that range of, experience applies to this specific patient as well? And in the accurate manner that I would. So you got to deal each case by case. So definitely with those fractures, I'm going to simply say, hey, can you get me your recent x-rays? Now, if that was not the case, why would the physician do an x-ray every 15, 20 days when the patient comes back to see them? Right? It's the same medical thinking. It's like, okay, they have seen tons and thousands of cases. They know what's the timeline is of a fracture healing process. Why not just send them home and say, hey, by 1 month, do this, by 6 months, do this, by this, do this, and then you're good, which could have been done, but you bring the patients back into the clinic. You're saying, okay, I need you to see me. I need to see this. And all that decision-making process is going in real time. That's the same thing I got to do because I see them more than the physician and I make more decisions after that care saying, yeah, put your foot down, put this much percent weight on it, and then now you can progress by this time into this much weight. I do need to see if that callus is bridging properly or not, if there is any screw that's coming out or not, if the patient's bringing to me a concern that, I feel a little pinch in there, what's going on? Are we having something come out? Or is there something that is not stabilized as well? Then those images help. It gives me an idea and it also comforts the patients.
Yeah, that's interesting because for people outside of clinical care, like let's say you have an ankle fracture and you get it repaired, you're going to get a boot and you're going to be told to not put weight on it as much as possible, and then basically not exercise. Like sometimes doctors even say like not to do PT until after the boot comes off. And so, but there's this period of time where your muscles are wasting, you're getting weaker, things are happening where you're losing a lot of time and losing a lot of strength, which is already really hard to get back. And so what he's saying is that he's tracking progress with ultrasound to say like, hey, if there's a sharp pain, you don't have to schedule a visit with your doctor. We can figure this out right now and see if we can put like 30% weight on your foot, or we can put like 50% weight bearing through that foot. And that's important because the sooner you can get back to weight bearing, the more your bones and your muscles can get used to putting weight through that foot, and you can get stronger faster. And right now that's not the case. And it's like, why is this something that's happening, and why aren't doctors doing this more?
We had a similar case talking on that and continuing it. There was a girl who was having multiple surgeries for different reasons. She had a graft and she was reconstructing the ankle. So they had actually put some skin and a lot of soft tissue just to kind of let that live on the ankle. So it was like a little blob sitting in there. And then she had a surgery done with a nail and a screw in there. So that nail was pinching her. So she was like, something pinches me. And because that was a big blob of fat on top of it, she couldn't say where it was, what it was. And well, the nail was actually in what initially was put in the ankle, but she was feeling it on the skin with about a 2-inch blob of fat on top. So we're like, I don't know what's going on. I did put an ultrasound in one of the exams and I was like, I think I see something. And that was a metal in there. So I'm like, I'm seeing a metal. This is not your tissue structure here. And I train and I follow it. The metal actually was going into the ankle joint, but it was actually sitting in that fatty tissue. So then what I said was, I was like, hey, it's not urgent. It's out there. You're walking. You're not feeling any issues with it. But this is something you need to bring to your surgeon, because the surgery has been done some time ago and you're not going back to your doctor for a good couple months. You don't know this thing is unstable if it pops out or something happens. So she did go to the doctor, and the doctor basically did the x-ray, and she brought in the x-ray, the next ray. She's like, this is what's coming out. It was
Right.
hanging out there. I was like, cool. So what are you doing now? She's like, I'm getting a repeat surgery and they're going to put this back in there.
Wow. But if you had not even like brought that up, you're like, oh, it's just part of the ankle healing or whatever.
Many times it just gets discarded like that. It's like, okay, well, yeah, you must be feeling something pinching, maybe like a little, structure pinching into your joint. You're doing PT. We know a lot of times people have aches and pains after PT, and they're like, this is sore, that hurts. We're like, okay, we'll keep monitoring it, but that takes time, and
Mm.
you're actually skipping time in that monitoring process. So you're not definite, and in some conditions you're not definite. So these are the places where you really want to be, avid, and then say, no, what, this is what I see. There's a trouble here.
Why aren't PTs doing this all around the country? Like, why isn't this like common practice?
Again, it's somewhat like, you got a history in there, right? So ultrasounds have started pretty early in, the military process in US, right? So uh, military PTs have access to so many things, and they have been doing it since a while, and ultrasound is no exception, and neither are other imaging modalities. But till now, we think we only have 6 states that have the access to ultrasound and imaging in different respects as well. They don't have all blown imaging access. Some of them have some part of it. Some of them have just the radiographs to it. So that said, there is some restriction that comes from the legislation, right? We do need that to be, worked upon. And I think APTA is doing a brilliant job in kind of getting that done. That's why we're seeing these changes coming up so frequently in the recent past. And in addition to that, then comes the mindset, right? It's like you got to work on that mindset of the people who are actually doing it. If they're not feeling confident about their ability to do it, then they're not going to even delve into it and not think about it. So that is something which is now being taken care of with the new DPTs coming into the picture, because they all have imaging curriculum added up to their courses, and also FSBPT and APTA are endorsing it. Even so, universities are bringing that in as it's becoming a part of their curriculum, and it's also being asked by the regulatory authorities to have in the system. So good, that's all coming up. As that becomes a regular part of it, things are going to start changing, but that's in the future. We have a big load of PTs that have been trained in the past and have not been exposed to this as much.
Mm.
So for them, it is still a new thing. For them, it's like, okay, and that encounters more or less with the civilian PTs in the States, right? So it's more or less like, okay, I have never done this. I don't know. And as I said, it is 256 shades of gray in ultrasounds. It is daunting, right, to look at that image. Even now with new PTs that come in, like I have, some PTs who come in for shadowing and stuff, right? So they are like, I don't know what I'm looking at. If you didn't point that was the a tendon, I would be seeing something there. So it needs to be a little bit more so in depth as far as the exposure to this material is concerned, and that's part and parcel of the reason why it's not as prevalent in the society and being used by PTs as much. Those who are interested are doing wonders with it, right? They're really going on with it. I know a couple of people who are just taking it to a different level, but then others don't even know. And then PT in another way is a pretty vast field in itself, right? Nowadays we have geriatric specialties, you have orthopedic specialty, you have the women's health, neurological health. So not everybody will also be interested in it, right? If someone who is just treating vestibular patients and doing balance treatments is not trying to find tendon tears in them. So for them it is more so like, okay, if I see something, I will refer them out to an orthopedic PT. So it sometimes is being looked upon as a specialty, like a subspecialty niche for people who are into orthopedics in physical therapy. But I think a basic elementary knowledge of these things, just as x-rays and MRIs, is needed.
And do you think that's going to help promote congruency among the profession to allow us to be more of diagnosticians versus just providers or technicians, so to speak?
So the field started with that, right?
Yeah.
The field began with the thought of a physician extender role as a technician, but obviously we have seen the field has grown enormously, right? There is no part of technicianship left in this field at all, right? We're doctorate level, providers at this point, and that's not just in the US, that's everywhere. To point out that I think our European counterparts are beating us here. They are expanding themselves into imaging, into regenerative medicine. They're doing PRPs and steroid shots. They're providing MSK medicines. So they're kind of like the NPs of the PT world back in UK and Sweden and those Norway, all those countries, Scandinavian countries there. They're pretty much up there. So yes, I mean, as far as diagnostician part is concerned, I think that just does not go away. It was already there and it's not coming in because of ultrasounds. We Yeah, I do see the point where it comes from, where you say, or where you look at it in the literature, where the division comes in, okay, there's a PT diagnosis and there's a medical diagnosis,
Right.
right? And I was amazed to see that actually there is also a nursing diagnosis. I didn't know that. I mean, I was like, okay, when I was reading for this, I was like, there's a nursing diagnosis, PT, and medical. You can call one disease with different names. I think that's what's happening. We're overcomplicating our system just
Significantly.
for the sake of yeah, exactly. So that can be avoided. I think we can just save ourselves and say, okay, this is, yeah, I know there is some movement limitation in that disorder, but there is a disorder, and that disorder can be called in the same way. If you got gouty arthritis, it is gouty arthritis for PTs as well. You
Right.
can't take away the gout crystals away from that and say, oh no, this is just a hallux pain there, right? And that
Movement
will
dysfunction of the ankle joint or the talocrural joint.
see, seriously, that takes more brain cells than anything else. So in that case, we're better diagnosticians coming up there from PT
Yeah,
standpoint,
right.
trying
Instead of
to.
saying low back pain, we say lumbago with unspecified like radiculopathy.
Now, to me, I think it feels like splitting hairs, right?
Yeah,
So
for sure.
it's not something that we should be doing. I think we should be focusing again back to your patient care. So patient care is more important. I would rather spend time simply saying, hey, my working diagnosis is this, and this is what I'm thinking, and these are my working points to it. Hey, physician, let's get in touch with and let's get a teamwork built up here and see where the patient can go from there. I would not even focus on that kind of a point.
Yeah, and I'm thinking, with it being in our toolbox, it had to have increased your confidence, at least as a diagnostician, because at least if you have a hypothesis of what something is, and all these things are adding up, but maybe there's like one symptom that's kind of funny, or like, I'm not sure. Has it been a good like kind of backup in regards to building your confidence of how to like identify what you think is actually going on with a patient?
Yeah, that's a good question. So I would kind of give it with an example on this. So there's a yes and a no to it, right? Again, it's because even before diagnostics, there is a good amount of methodology that goes into creating a working diagnosis. And yes, working to that hypothesis that you would say of. So that said, I mean, we had a case where a patient walked in with shoulder pain, right? Referred from an orthopedic surgeon's office, and just like a regular shoulder pain and rotator cuff, tendinopathies and so on. So started examining the patient. Everything else was pretty much normal in that patient. The patient was able to move the arm all the way up, and there was no trouble. She was basically going everywhere. And I'm thinking, what's going on here? And everything feels pretty straight, and the patient's not having as much pain. Just doesn't add up, right? It's like you can even go back. I'm like, okay, or even the tough positions for that rotator cuff are being overstretched, and there is no trouble. What am I missing here? There was one thing that was kind of showing up, is that the manual muscle testing was not adequately in line with the range of motion testing. The motions were going pretty good, but the manual muscle testing in specific ranges, you're looking at those, external rotation, and you're looking at the abductions. Primarily, the external rotation in that case was pretty much off. I was like, you're not having strength in that, but everything else looks good, but you're able to still move it. I had to take out the sonogram. And this was after talking with that patient for about, 30 minutes, 35 minutes. And I was like, I think I got to do an exam on you. So I bring the sonogram out. And once we put that, I was like, I'm not going to go everywhere because all the other joint, structures seem to be fine. You're pretty much you're not painful. I just straight away put it on supraspinatus there. And I wanted to see that straight out. And long and behold, that tendon was not there. It was delving into, there was an opening. Basically, the deltoid was sitting on top of the humerus, and the tendon was missing. Infraspinatus was there, right? The teres was there. So rest of those structures were the one that were actually compensating for that motion, but that tendon was missing. Mm. So in that case, yeah, I mean, I did get confidence in stating back to the patient saying, you got a missing tendon? You don't belong in my clinic. I don't think so. I can, do anything to this tendon unless you decide you're not going to get a surgery done, right? I mean, yeah, if you're deciding you're not going to get a surgery ever for any reason, then yeah, I mean, I'm sure your surgeon's going to send you back to PT and say, well, that's the best you can do with it. But obviously the patient went back 2 weeks down the line. She got the surgery done and came back to us again. We did the therapy after that. Pretty fine, normal rehab surgery, normal rehab after that.
Right. Yeah. So, I think it's interesting because the fact that you can kind of reconfirm your hypothesis, because I've had the same case where same thing, rotator cuff. It was just something's not adding up, but I referred out to the MRI, and it lo and behold, they did have a rotator cuff tear, and certainly makes you feel more confident as a clinician and being like, okay, I do know what I'm talking about, or at least I can identify when something is not right. Like this isn't, like you said, like everything seems normal, our range of motion looks fine, but for some reason it's just not adding up. And I think having that tool must be very nice to at least fall back to when needed.
Exactly. Yes. Very true. Very true. There was actually a recent case 2 days ago. We had one like that where a patient didn't want to come actually. He was like, I'm feeling okay. I had a tear, but in the gastrocs. And he's like, I just didn't even want to, come to PT for an evaluation. I'm like, okay. But he was like, well, because I'm here, I know I have knee pain. Can you just, do PT on that? I don't know how that works. I'm like, well, we can examine everything and just kind of see. I was like, well, where did you have the tear? Like just somewhere down in that calf. I just started palpating. And just with palpation, he had a lot of pain, right? In that soleus area. So I was like, you still have pain, right? He's like, yeah, I do, but I think I'm doing very good with everything, my movements and all. So I don't think anything I need to do with this. He was not buying in for any reason. I mean, a half an hour, I'm like, I examined everything. He was just not taking. He's like, he was convinced that his 2 months of just sitting at home and relaxing healed him, and he could go back and ride his Harley. That was his kind of going back. I'm like, you're going to lift, drive that bike and put all weight on that. You need to be really sure that are you going to handle that or not. So I think last thing that I had to bring up was, again, I was like, okay, let's just spend time and look at this inside. He's like, oh, you could do that. I'm like, yeah. So well, first he was pretty amazed at that. He's like, oh, you could see it in this clinic? I'm like, yes, we can. And then we looked at it and there was a decent big power Doppler light up on it. So that signal had a lot of fluid retention within soleus and a good big black tear in there. And I measured it for him. It was 2.06 centimeter in its length.
Wow.
And which was from his MRI, it was 2.16. So he basically just reduced by what 0.10 centimeter in there. Now, like you just
Healed.
improved.
He's all healed.
Exactly. So it's like, this is what you had. Then by the end of the session, he was really thankful. And he said, well, I'm glad I came in and I'm going to follow my precautions and just not go back to biking at this time, at least.
Right. Yeah, I know. 2 weeks later, it could be a different story.
Right.
Well, overall, I guess, has it allowed you to find other things that maybe you weren't like familiar with, or maybe trends that you wouldn't have expected just having that tool in your toolbox? Maybe like you said with the rotator cuff, like you had a patient who came in with the arm and they had full range of motion, and then you're like what made you like look at the supraspinatus versus like other muscles? And are there other trends that you're noticing that the ultrasounds allowed you to kind of notice? It's like if these objective measures aren't coming out, then maybe I should look at this, and this is what it usually is.
So again, different cases, different approaches, right? So you're looking at different joints in a way, and you're looking at their function primarily. So just as in supraspinatus case, right? It was just that one muscle group that was not performing well. Rest of them were really good, and the patient didn't have pain as such. That no pain and no strength doesn't, it straight away leads to that, thought process. Okay, I think you don't have a muscle that is performing the function. You tore the fibers completely, so you're not having the pain anymore. So that's my hypothesis in my mind. But I can't say it out loud straight up because, well, it's a big panicky situation. You basically saying a person who just came back from an orthopedic surgeon's office for PT and saying you're not ready for PT. Right? That's a big difference of opinion that you want to substantiate in patient's mind. So you got to have some amount of trust in there for that. So that's a decent trust building process, and that's one case. Again, in that case, there are various cases. Again, I had like a biceps tear in a patient, a really old lady, about in her late 70s, and I kind of realized that in that age, even reaching out to the shower head can cause a biceps tear. Yeah. So, patient came back with black and blue, image on her, the skin was fully, colored up there. And I was like, well, I think you broke yourself, or what, is there a fracture going on in there? Did you fall? And with her age group, I was not getting a straightforward answer. I mean, it was hard to even get the history correctly out of there. So I was like, well, I can't do much out of this. I don't have x-rays in here, but I don't know if you need to go to an ER at this point, because you're coming to me. She was scheduled for PT long time ago for shoulder pain, not for the biceps. And she fell yesterday for that, and she didn't go to the ER, but came to us instead. So, well, in that case, I had to pull the probe out, and I was like, let's look at it. And there was a biceps tear, sent back to the physician, and physician basically initially put her on a little bit of anti-inflammatories, gave medications, gave a little rest, ice in, and then obviously wrote another script for PT afterwards. So then we started PT within about a week. So it was not a long break for that. And we started really conservatively on her. So yeah, those cases do come up, and it's more or less like a judgment call on who do you want to, start examining like this. So, yeah.
Do you feel like your role as a PT is starting to change more into the role of like a primary care role? Just knowing that somebody came to you first before going to the ER for a biceps tear is intriguing to me. And do you feel like the role of what you do at your clinic is changing?
It definitely is. I think it kind of brings memories back to me. Frankly, when I started my journey, it was more so like that. So my role was already in that zone when I started back in New Delhi. So I when I did my bachelor's there, after that, when I started my own clinic, that's what we would do because they were in India. You can, as a PT, do all this. You can do imaging. You can refer to blood work. You just cannot prescribe medications, right? But apart from that, you can basically be a triaging officer for the patient. So that said, it was more so of like, okay, I'm kind of doing the same things that I used to do before, and that's primarily what it is. And I think in the States, that's what's happening at this point. And clinicians are kind of realizing that, yes, as PTs, specifically PTs, I think we are pretty much trained in the MSK system, real detailed. So our examinations are high quality examinations in MSK, evaluations. So if we are looking at those systems and we are, sending patients out for any kind of diagnostic imaging, it's well worth it. It's definitely, it has its basis behind it. It's not coming out from a 5-minute evaluation and saying, okay, your shoulder hurts, let's get an X-ray. No, it's definitely not there. And yes, I think the role is transitioning and should transition to a primary care MSK, provider. And that is something I think I see everywhere now, around me and people that I am in touch with. It's not happening in a large scale, but people who are into this, that's something that I'm looking at and the direction in which PT is going and should go.
Is there an argument against perhaps the profession heading in that direction? Because for every person who thinks it should go one way, I'm sure there's one person who thinks the other. So I guess, is there an argument against that idea?
I think there must be multiple arguments. Nobody has argued with me till now.
Well, I
So,
don't mean to. It's just more of like, I know there's always going to be a devil's advocate out there asking, like, okay, well, hey, should we be really doing this kind of thing? And I know primary care is kind of this weird area of medicine, and it's certainly a very difficult role just to fill in as a physician. And I'm wondering if PTs should be the ones to fulfill that role, or if we should continue just staying in where we are in our wheelhouse of like musculoskeletal care and exercise versus like dealing with the person who comes in with cardiac issues for however long, so to speak. So I guess what would is there an argument for against that, or
so the argument again for against it, I don't see an argument against it. Again, there must be some, but it must be coming in from a different perspective.
yeah.
How I see is there are arguments filled for it by all means. Um, if I'll divulge from this and go into the point of cardiac care, right? As you said, well, we have PTs in cardiac care first, right? So there are cardiothoracic PTs who would be really interested in kind of evaluating those issues as well. Now, by all means, if someone is coming with obesity, high blood pressure, and these multiple other disorders, you can't just ignore those disorders and say, I'm not going to look at that and I'm just going to look at your knee or your joints, right? What if I have to evaluate and treat their knee, and if their cardiothoracic system or their cardiorespiratory system is not at their best, they can't even ride a bike for me to warm up, right? So in that case, I need to understand what are their limitations and how much we can push those limitations to get the best results out of it. So in that way, I kind of remember a quote that my professor told me in my professional PT school back at home. It was he said that when a patient comes to you with one, joint pain, right, back pain, knee pain, when they come to you, they're not a chapter of your book. They are the book. So they will have all the issues, comorbid issues in them when they come to you, and all of them are affecting them. If their knee joints are wearing out, perhaps it's their BMI, which is over 40, that's affecting it. So having a small conversation about the patient saying that, hey, are you in touch with your dietitian, or are you making any amends towards that? Because that's going to help you out. This is real base minimum that I'm saying. I mean, again, there's a teamwork that works towards this. And but at least PTs being a part of it can start, involving themselves into these kind of conversations. I think we have a responsibility towards that as well. So it's not something that's out of the realm of understanding of a PT that, you can't do these things, you can't talk about this. So I don't see an argument, against it. What if a patient who has a stroke, if you track that patient's history and you're looking at how many providers they have seen in their life, and if anyone could have tracked or found out some of those nuances that could have led to the stroke and pointed out to them in a timely manner, I think we could have avoided one stroke there.
Hmm.
And it's possible in different cases, heart attacks, strokes, patients or young people, well, people become patients. So young people are getting heart attacks in 30s. That is astounding. And one should not be having a heart attack in 30s. I have seen in my career a heart attack at the age of 18 in a patient, a silent one, right? So just talking about saying, hey, have you ever got your cholesterols checked? Ever? I'm not saying that everybody now goes back and starts getting blood work done for any reason. Yeah, I'm pretty healthy, I need a blood work done. No. Well, annual checkups, I think even WHO says if you are hale and hearty, every 3 years at least get a checkup once, right? Just say hello to your doctor and say, I just wanted to kind of get screened out. Fine. You're completely okay. You don't have to come back to that doctor for the next 3 years. If you have an ailment, then yeah, you should get an annual checkup done. At least monitor those things. You monitor it doesn't mean like you're trying to, think about that disorder all the time. You're simply saying that, okay, I'm just keeping track of this and I won't let it get worse. Right? So those preventive healthcare, preventive medicine aspect of life is a part of PT. And I mean, PT, dietitians, we're all kind of a team that does that. So having that education based conversation with the patient is not something that is, out of our course.
Certainly. And I think it's treating the whole patient, right? And we're kind of playing in this idea of like lifestyle medicine, where we're saying, let's take a look at everything that you're doing in your life. And we're going to evaluate that and treat everything that's going on with you. And like you said, like you come in for knee pain, but your BMI is 40, or maybe you're light, but maybe you're, maybe you just start picking up running or whatever. It's all the little things that kind of go into what the patient is presenting with. And those are all the factors that we need to consider. And I think PTs have tried to start moving in the realm of that lifestyle medicine.
That is true. Very, very true. I do engage into that personally as well. And I had actually read this pretty neat statement, and I'll quote it from Lifestyle Medicine, from their college, American College of Lifestyle Medicine. They basically said that as a part of lifestyle medicine, one should engage into evidence-based medicine as a supplement to lifestyle medicine modalities given to a patient rather than vice versa. Which nowadays it's the case. It's like when you go to a doc, you basically get medicines first, and then maybe a disclaimer kind of an advice at the bottom saying exercise and diet will help you. Go for it, right? Most time is spent on the medication part of it. So it needs to be flipped around. Because if we're talking about lifestyle disorders, they're basically disorders that happen due to changes in lifestyles. So I think lifestyle becomes the major factor that needs to be reversed or worked upon to find a cure for these issues, right? And I'm not using the cure word myself. It is actually in the American College of Lifestyle Medicine board review book. So I know cure word is a little bit sensitive. We don't want to use it as much, but that's where lifestyle medicine comes in from. So I think yes, it is another area where PTs definitely need to get into, and the idea of sharpening your skills in differential diagnoses, it's a part of it as well. Um, if someone is not looking at a person as a whole and utilizing all tools in the bucket, it's not going to work. And there was an early on example in my career where this patient came in with shoulder pain, and the patient was basically a elderly female, I would say late 50s, and the patient had shoulder pain that was kind of going on for a week or so. And once I examined the shoulder, it had minor changes with movements, and but not major ones. So didn't see many patterns in it. No capsular pattern, no labral issues, no special tests kind of jumping out of the way and saying, yeah, it is me. So in that case, I was like, well, I'm just going to take your blood pressure. How do you feel otherwise? So took the blood pressure. At that time, the blood pressure was astounding. It was around 200 by 120. So I was like, what is your normal blood pressure? So she's like, I don't know. Never took it. So I was like, okay, let's send you to someone. Now there was nighttime when I saw her, and see, she didn't want to go to a hospital or ER, so she finally just was convinced to see a cardiologist that lived, close by her house, and who was, okay to see her at that time. He did see her, and then did give her medications, did an EKG, and sent her back home. I was like, she told me that, and I was like, okay, fine, let's just monitor you for the next 3 days. Monitored her every day, same time for the blood pressure. It didn't change an ounce there.
Wow.
So I was like, well, okay, come back to me. And the third day, I was like, well, let's examine your shoulder. How is that? Because that still persists, right? So my PT problem is still there, and I'm not doing much about it. So I was like, well, let's examine that again. So again, first thing here I'm doing is going into differential diagnosis as a clinical exam again into that patient, not jumping to imaging. We're still not pushing that. But at this point, I'm like, I have to fully palpate the whole shoulder around areas. I find lymph nodes that were actually swollen in there. And I raised a red flag. I was like, for this, I'm not alarming you. I don't want to scare you, but I think we would need to see someone in this area. And I had a gynecologist referral I knew, and I was able to make that referral. And the gynecologist was really supportive of that. She brought the patient next day in there, did the mammogram in her own clinic, and she was a stage 3 cancer
Wow.
of the breast. So next year or so, they basically spent 6 months in chemo, and then they had radio, and then they had finally mastectomy also. And she lived after, so it was good.
And she had to come back to the clinic and thank you for taking her blood pressure and being diligent.
Actually, the whole family came in, so we were friends after that.
I would have to say so.
Yeah.
But
So
it's
I
those
think that
examples there where you need to realize like that you need to be looking out for everything just because, I think it's very easy for us to forget all the stuff we learned in PT school where we like the cardiology stuff and neurology and everything else where some of that stuff goes to the wayside because the day to day is more important. Like you're seeing knee replacements, so you're seeing meniscus tears, you're seeing rotator cuff tendonitis, you're seeing low back pain, and that one person who comes with that shoulder pain you can't really figure out. It's like, well, now's the time you got to be diligent and be a diagnostician.
right, exactly. I think that's where mostly it's like, oh, it's not improving. Let's send you back to your doctor. Let him do the work.
Right, exactly. Yeah, just to refer out. It's not my problem anymore.
Exactly. Yeah.
And I guess when we think of treating the whole patient, you're seeing them and you're thinking of, all the different things. But I guess are there other people who you're building a team with to try and think of a way build multidisciplinary care at your clinic? Are you trying to build, because you mentioned dietitians are kind of in the same realm of like trying to do this treating the whole person approach, and have you built like a good team around you community wise to help with this?
Right. So I have not been able to find a dietitian. I kind of work in a really small town here. So I currently don't have uh, that part of the team, but I do have internal medicine doctors and obviously orthopedic physicians and surgeons with me whom I can communicate with. And there is a psychologist that I know. So things on those lines, like again, it's more or less like by word you get to find people around. So that is there, but that's definitely a community effort, and it's an ongoing thing, right? You can kind of have people come in and go in the healthcare sector, so it's on you that you keep maintaining those relationships. And yes, definitely, I do that on a daily basis with my peeps and people around.
That's great. Yeah. And I think that's just benefits the community all as a whole and everyone else, because you get to build those relationships, you refer patients to them and you trust people and you build that communication. You're always having this community approach, so to speak. And I think that's when patients can benefit the most.
Exactly. Yes, that is true. I think I have, in a funny way, I did get a referral for, I think we were talking about this before, about a slip rib syndrome. And that was from a nurse practitioner because she couldn't find someone who would do that dynamically. So she was like, hey, I need this patient to be examined as fast as possible because the patient has had so many examinations, but all of them are static examinations, and there's nobody who does that ultrasound on them to dynamically move the ribs and simultaneously see if they're moving around or not. I was like, yeah, why not? So I kind of overstayed my time in the clinic. I was like, let's do it. So she comes in, sends the patient, and then we just kind of look at it. It was a negative one, but at least there was a negative, decision making process, and the diagnosis was like thrown out of the window. Next thing.
Right.
So it does help. And yes, with that kind of an approach, your providers love you because okay, yeah, you're available for them. They're available for you in the same way.
Now, are there new tools on the horizon that perhaps we need to be looking out for? Maybe I know you dive into the research a lot, so I'm wondering if there's any new tools or on the horizons, or maybe just new versions of the same thing that are coming out that we can maybe be on the look for to try and educate ourselves on or know more about.
Well, yes. So for it to speak about diagnostic ultrasound specifically, well, yes, there are machines that are coming out. Ultrasounds are becoming more and more readily available for all, and they're becoming portable. So some of them are as small as your cell phone. So which is really neat to see, and big companies as well. I think GE is already in there, and you have the new ones, Clarius, Butterfly. They're already working on this and bringing it up again to different communities. And what I am trying to see as a trend is the inclusion of artificial intelligence. So AI in ultrasound, and I think overall in radiology, it's kind of becoming a new thing that there is being on a talk, just because, well, the radiologists are overwhelmed everywhere, just as any other provider. So in such a case, artificial intelligence is really great at kind of picking up things, especially when there's so much data that we have on radiology. If you feed that into a system and the system learns it, it tells you back those things and picks up stuff. So that is neat to see. Like the ultrasound that I use, I'm able to kind of, it doesn't do anything in MSK, which is kind of a shame at this point. I don't see any kind of a tear detection mode in it, which might come later on sometime. But like they have bladder volume detection, so you can just put it on a bladder, and you can actually see how much volume is being retained in the bladder. You don't have to calculate, no formulas. The system does it for you. Cardiac output on an echogram, it does that. So if you put it on there, on the echo, it shows you how much cardiac output is coming out. I think those are the kind of changes that will drop into every field.
Mm.
And I'm looking forward towards the growth of elastography in diagnostic sonography, which is relevant, I would say, relatively new to this whole field. We don't have a lot of literature on elastography as of now, but it's growing. I do see articles coming up on it, and I have a couple of friends who are using it. So that is another thing which basically tells you, just as an intro, it tells you about the tissue elasticity, basically how rigid is the tissue, how soft is the tissue, which is pretty relevant for tissues that have tears or tissues that may have some kind of a cyst going on around in them. So things on those lines, right? So that's a new thing that I kind of like.
And is that what you're most interested in excited about for the future of PT, or are there other things that perhaps that you're excited about? I know for me, the realm of PT continues to grow, and the more information we get out there, the more it expands and the more people know about us. And I think it's great. But are there other things that perhaps you're excited about for the profession, or at least maybe with ultrasound?
Personally saying, I mean, I'm working on a couple of studies. So I'm kind of looking towards case studies and case series that I am working on, and hopefully that I'm going to put them out next year. So I'm looking forward to that. And as far as the professions growing up, I do like the primary care MSK role of the profession. And I think as we've talked about it in detail, that is something that I would be really, really, looking forward to as it grows up and becomes the main part of PT rather than just, physical therapy as in itself. So that's I think what would excite me at this point.
Certainly. Yeah, it excites me too. I think it's something that we can use. And I think I've even seen it in pro sports. Some teams have been using it to help diagnose some of the athletes.
Absolutely, yes, yes. The athletic trainers have kind of started using them as well. And athletic trainers, EMTs, they all have these portable ultrasound at this point to their disposal. And just it's pretty exciting to see. Like on the field itself, you can say, okay, yeah, this patient's got a tear, no more. Let's get him out of the field. And this one's good. Send him back. Put a cast net, put a strap on it. there you go. You're running in there. So yeah, and well, sports. Well, I did my master's in Pittsburgh. Are you Steelers fan or not?
I'm not. No, I'm actually a New York Giants fan, believe it or not.
Okay, cool. So
Yeah.
I'll take that. I lived in New York, so then I'll agree with that. I'll take it. I
Yeah.
know Steelers were not doing good, so I'm not watching or kind of following it as much. They lost 3 games out of the 4 they played, so nah. But yeah,
They
I think
they
I'll
beat
go
the
with that.
Bills week 1, so there's a little bit of potential there.
Yeah, I see that. Agreed.
Well, listen, I appreciate you spending time with me today, and we're kind of wrapping up with the to the end here, and we're closing up on the final remarks. And I just have a couple questions for you for the last portion, and if you're ready for them, we can kind of ask and shoot away.
Sure, go ahead.
Sure. So this is the health me to health you portion of the podcast. First question: if you had the attention of everyone in the world for 30 seconds, what would you say?
I don't even have that much attention in my own house. So okay, if I had to, well, I would on a serious note. Again, I'll speak from lifestyle medicine's point for. Uh, if everybody has the attention 30 seconds, man, start early in your life to take care of your health. That is the biggest thing you'll do. I'll put my dad's saying in here. He says you get to know how people live in their 50s and 60s by the way they have lived their 20s or 30s. So keeping that in mind, start early on, take care of your health, look at your diet, work on it. I think it brings a better society around us.
I think that's great advice. I think I see so many people in their 50s and 60s. There's like, I wish I worked out when I was 20 or 30. I'm like, yeah, I know. You're the 300th person who told me that this week.
Absolutely, yes. Yes.
Second question: what book do you recommend, whether book you're reading now or in the past?
I think I'll give you 3. So, first one, I'll give you one from the past, one that I'm reading, and the third one is from ultrasounds. So, anyone who loves ultrasound, that's the third one for them. First one would be Breath Becomes Air. This is a book by Paul Colonity. He was a neurosurgeon. He passed away in 2015. Pretty young guy, physician from Yale, and a neurosurgeon who got a diagnosis of his lung cancer, stage 4 lung cancer, right? Pretty moving story about him. And I won't give everything if someone wants to read it, but it does raise a lot of questions for people who want to understand empathy, people who want to, as healthcare professionals, I think empathy is a big part of it. So people who want to look at that, it's an important way to understand life when, life is literally ending at your face. And to add to that, okay, I'll give one more thing out of it. He also got to know that his wife was pregnant. So within a year, they were going to have a child. And within a year was his diagnosis of basically going away. So it was a life coming and a life going simultaneously. And he kind of worked through that process in a real beautiful manner. That book is a gem. I think it was my fastest read.
And then
So
what about the one you're reading right now?
the one I'm reading is called Karma. It's a book by Sadhguru. He is, I think, the founder of Isha Foundation. And basically, the book is, it kind of debunks the myth of, how we know karma as a cycle of, good and bad, right? Kind of takes you out of that and basically says, you're in the driving seat of your own life. And I'm quoting basically his words here. So you can make the changes that you need to. Uh, and it also explains how your own karma decides your own cycle. You kind of create that for yourself. Again, it's a pretty detailed book and a good read. I'm reading it slowly. It's not my fastest read.
Sure.
So that's definitely something to look at if anyone's interested on those kind of answers. And the last one, right? The ultrasound one. So that one is a big book. I think I should have it here somewhere. And I think I will read it for you. So that book needs to be read by anybody who loves ultrasound. So it's the Ultrasound of the MSK System by Bianchi and Martinoli. This is the book, I would say this is my first purchase. And I still read it. I have not completed it. It's a referral. It's kind of my reference. It's kind of my textbook. But that is one book in your kitty. If you are interested in reading and understanding ultrasounds, you must have it.
Certainly a heavy read, definitely not a light read. For anyone who's listening and not watching the video, he held up a book that's about like 14 inches thick and held it up to the screen. So it's a big book. So be prepared if you go to look for it on Amazon.
That is true. Yes, it is available on Amazon.
Last question: where can people more find out about you and learn more from you? If
So anyone, I mean, I'm pretty active on LinkedIn, right? So anyone can search my name, Shirish, and I'm active there. Or you can email me at Shirish, Shirish, dpt@gmail.com. So I'm available for that. And I mean, I'm pretty much open to any kind of questions, comments, concern regarding MSK ultrasounds, PT as in general, lifestyle medicine. Those are my areas more or less that I look at.
Thank you so much for coming on the podcast. Truly appreciate it.
Thank you very much, Mike, for having me. It's a pleasure.